Good morning, everyone, and welcome to Semel Grand Mountains. I am incredibly excited and honored to be able to introduce our speaker, Dr. Stephan Heckers, who's joining us this morning. Dr. Heckers has a distinguished background, having attended medical school at the University of Cologne, Germany, and completing his medical training in psychiatry at Massachusetts General Hospital in Boston. He then served as a faculty member at Harvard Medical School from 1997 until 2005 and was the director of the Schizophrenia and Bipolar Disorder Program at McLean Hospital until 2005. Since 2006, he's been serving as professor and chair of the Department of Psychiatry and Biobehavioral Sciences at Vanderbilt University, holding the William P. and Henry B. Test Chair in Schizophrenia Research. Dr. Hecker's research focuses on the neural basis of schizophrenia and bipolar disorder, and he's explored the mechanisms of memory deficits in psychotic patients. He's the recipient of many awards, including the Paul Janssen Schizophrenia Research Award and the A.E. Bennett Award. He is also a member of several editorial boards and of the Scientific Council for the Brain and Behavior Research Foundation, and he served as the editor of JAMA Psychiatry for 3 years, from 2015 to 2017. Today, Dr. Heckers will be speaking on catatonia, a topic on which he has published extensively, with articles in the New England Journal of Medicine, JAMA Psychiatry, and Lancet Psychiatry, among others. Despite being recognized in the medical literature for centuries, catatonia remains a topic of a lot of uncertainty and confusion among not only students and trainees, but even more experienced attendings and faculty. And I'm hopeful that Dr. Hecker's talk this morning will help to bring us all up to date on this condition and help us feel more confident when we encounter this in our clinical practice. So please join me in welcoming Dr. Heckers to Grand Rounds this morning.
Thank you, Jonathan. It's a pleasure to be here. Of course, I would prefer to be there in person, but I think you will have to do with me being here in Nashville, Tennessee. I have no conflicts of interest to declare other than grant support from the NIH. I hope that after the end of the hour, you will have a good appreciation of how we have thought about catatonia over the last 150 years. You will also be able to identify, name, and characterize the signs and symptoms of catatonia and have a basic understanding of how we approach the treatment of catatonia. All right. I want to start my story today with taking you back to the 1870s in the central part of Europe. At that time, Germany was created as a state in 1871, and it was a small city in the eastern part in Saxony called Görlitz, where a psychiatrist with the name of Karl Karlbaum was running a private psychiatric hospital. He did not pursue an academic career, but over the course of his entire life, took care of patients in a hospital setting, and by observing his patients was able to define several entities, including catatonia. He published on this for the first time in 1874, and the translation of the title is Catatonia, or Tension Insanity, a Clinical Form of a Psychiatric Illness. In his 1874 monograph, Karlbaum described 20 cases. You can see at the top the number of cases from 1 to 20. In the next row, you see the severity of the catatonia presentation, ranging from 12 signs in patient number 1 all the way down to merely 3 signs in patient number 20. And then in the rows, you see the frequency of the catatonia signs, starting with the most prevalent one, mutism, second being stupor, and ending all the way at the bottom with iterations in only 1 out of the 20 patients. You will also appreciate that at the bottom of this table, you see D and M, indicating whether the person was diagnosed by Karlbaum at the time when they presented with catatonia to be either in a depressive or in a manic episode. And you will notice that 16 out of the 20 patients were diagnosed by Karlbaum to be in an acute episode of a mood disorder. Quite interesting, because things changed very quickly, and it was an exchange of ideas between those two psychiatrists, Karlbaum on the left and Kraepelin on the right. Carlbaum was about a generation before Kraepelin, and even before he published his monograph on Catatonia, actually for the first time proposed a new nosology of psychiatric disorders in 1863. And this nosology, he felt, needed to be based on longitudinal observations. Rather than identifying only one episode, we need to actually spend time with patients over time, and by doing so, can clarify illnesses as defined by episodes as well as course and outcome. Kraepelin built on that and literally used Carlbaum's approach in his own nosology, which he published in 8 different editions of his textbook of psychiatry. And I've highlighted here the 4th, 5th, and 6th edition of his textbook, because that's when he built out of clinical observations what we now know as schizophrenia. And he defined hebephrenia, catatonia, and dementia paranoides. Kraepelin devoted a lot of his energy to his textbook. You can see here the 1st through the 8th edition. I plotted here on the y-axis the number of pages. You can see that in the 8th edition, it reached almost 2,000 pages. The red portion of the stacked bar graph shows you the text devoted to dementia praecox, now known as schizophrenia. You will notice that the first 3 editions didn't include the diagnosis, because it took until the 4th edition for Kraepelin to even introduce the idea that there was an illness like dementia praecox. Now, Kraepelin had high hopes that there will be 3 different ways of validating psychiatric disorders. He himself was a clinician, and he believed that an astute observation and longitudinal observation of patients will lead to the definition of clinical syndromes. He then also worked quite actively in recruiting scientists, among them Nissel, Alzheimer, Brodmann, to work with him to define the neuroanatomical underpinnings of psychiatric conditions. And he was also interested in exploring etiological mechanisms that included genetics. And in fact, he created the first Institute for Psychiatric Research in 1917. And he believed that when all of those different approaches converge onto individual entities, that we will then identify so-called natural disease units. Well, how did he go about this? How did he actually define, or even better to say, construct those disease units? So let's look at these editions of the textbook. So the first time dementia praecox was mentioned by name was in the 4th edition. But here he simply used another name for a well-known syndrome called hebephrenia, which had been described prior to Kraepelin by an assistant of Carl Carlbaum. In the 5th edition, he made a rather significant change. Kraepelin now introduced a new idea. The idea was that there are 3 different, previously separately defined clinical syndromes: hebephrenia, catatonia, and dementia paranoides, that could be grouped together under one new rubric, and that was metabolic disorders. He also had already etiological speculations about the mechanism of how these disorders come about. Then in the 6th and 7th edition, he let go of the metabolic disorder definition, elevated dementia praecox to be the new term for all 3 conditions together, then also extended his speculations to include a chemical lesion of cells in the cerebral cortex. And in the final large edition, almost 2,000 pages, he split dementia praecox into 10 different subtypes and separated from that a late onset form of dementia praecox called paraphrenia. He finished his scientific career believing firmly that Alzheimer had identified the anatomical underpinnings with pathology in the supragranular layers, layers 2 and 3 and 4 of the cerebral cortex. And he also continued to speculate about a chemical substance that leads to changes in the cortex and ultimately the clinical symptoms. So that's how he identified the clinical features to come together with anatomy and etiology. Now, there was significant criticism of this concept. In fact, Adolf Meyer captured it nicely when he said Kraepelin bends the facts of psychiatric observation to the concept of disease processes. In short, Kraepelin used clinical observations to then justify and validate his scientific concept of a natural disease unit that could be studied by clinicians, by anatomists, and by geneticists. So in short, the Kraepelinian paradigm that really was defined for the first time in the 4th and 5th edition, particularly with the definition of schizophrenia, as we know it now, starts out with the notion that psychiatric disorders are natural kinds. They exist in nature. We can study them as objects, either by studying the brain or by studying clinical features. Secondly, that of all the different validators of the illness, outcome is the most important one. And lastly, out of all the clinical features, Kraepelin elevated a lack of will or avolition to be the core feature of dementia praecox. And now we are getting a little bit closer again on the topic of catatonia, because volition or will is at the core of the catatonia definition. Kraepelin actually in his textbook outlined various abnormalities of volition and action, including drive, the volitional act itself, the abnormal execution of willful behavior, the ability to be influenced by outside forces, such suggestibility, or potentially the compulsive engagement in actions. And he used that approach to then define various aspects of abnormal volition. And this is all listed in Kraepelin's textbook as a core feature of dementia praecox, not just catatonia, but dementia praecox. And here you can see the significant influence that the catatonia concept had on Kraepelin's concept of schizophrenia. The psychiatric historian German Berrios in the 1980s, reviewing this literature, concluded that psychiatry still lives in a Kraepelinian world, and that scholarship on the work of Kraepelin has subsequently or consequently been unhistorical, and that we as clinicians cannot escape this blinding embrace of Kraepelin's episteme. We know this all too well in the United States because in the 1970s, the psychiatry department at WashU revolutionized our current nosological system in psychiatry, the DSM, by proposing that there are new approaches to validating psychiatric entities. And they chose schizophrenia as an example to define 5 different validators of a psychiatric diagnosis: clinical description, very much like Kalbaum and Kraepelin, laboratory studies, the limitation from other disorders, so let's say schizophrenia versus bipolar disorder, follow-up studies, again, very much in the context of Kraepelin and Kalbaum, and ultimately family studies or genetic studies. This was the 1970s. This was then the foundation for the revised version of the DSM, the DSM-3, which came out in 1973. 20 years later, in 1990, Ken Kendler, who was at that time already serving on the DSM committee, extended the list of 5 validators to those and grouped them into either antecedent validators, concurrent validators, or predictive validators. And you can see the list here. Highlighted in red are those validators that are considered to be the primary validators for the definition of new psychiatric diagnoses. So if you ever were interested in proposing a new diagnosis to the DSM, which happens every couple of years with a new edition of the DSM, you would need to provide evidence along those 4 lines of investigation: family studies, diagnostic consistency over time, the overall functioning over time in the person diagnosed with the illness, and response to treatment. So we see now that in 1990, we are having concluded again that the validators of psychiatric illnesses resemble the Kraepelin concept. Now, psychiatric diagnosis, not natural kinds, are at the center. Clinical features are now predictive validators. Anatomy or laboratory tests are concurrent validators, and genetics or epidemiology are antecedent validators. That is still Kraepelin's episteme in which we work, whether it's the DSM or ICD. But a very important switch here. Rather than converging statistically with statistical tests, we actually believe that these natural disease units will lead causally to the clinical features. So there's a pathway from etiology to, on the one hand, changes in the brain, and on the other hand, changes in mental states. That is the underlying philosophical premise, that we are not only statistically look for associations, so-called validation, but that we also believe that there is a mechanism of illness from genetics and the environment to the generation of changes in the brain and behavior. Now, more recently, people have become a little bit more sophisticated, and rather than lumping all clinical features together into a syndrome, they are now trying to identify individual clinical features, clinical feature 1, 2, and 3. Think about, for example, the 5 criteria A for schizophrenia. So rather than treating clinical features as a unit, we are now separating them from each other. And then one step further, we can then, of course, test for any relationship between those clinical features. So how are they, the criteria A, for example, correlated with each other? And here, this provides an opportunity for some hypothesis testing, because it could be that some of those clinical features are a little bit distinct from the others. So we can identify a separation of one aspect of the illness, catatonia, from the rest of the syndrome, schizophrenia. And this is exactly where we were in the DSM-5 committee when we reviewed the diagnostic subtypes of schizophrenia and the overwhelming evidence that catatonia should be considered slightly different than the rest of the clinical features in schizophrenia. So how do we go about this? How can we carve out, and Max Fink would say, rescue catatonia from the embrace of schizophrenia? How can we find evidence that catatonia should be treated separately from the other constituting features of schizophrenia, which is disorganized thought, hypophrenia, and dementia paranoides, which means delusions and hallucinations? So let's go to the evidence that we have. Kraepelin proposed in 1913, in the 8th edition, that catatonia can be diagnosed simply by observation, and he actually published this now somewhat infamous figure in his textbook, which made it onto the cover of the British Journal of Psychiatry in an artistic rendering in 2019. Many depictions of catatonia can be found in textbooks. This is a rather striking example of the English translation of Kraepelin's textbook, the 6th edition, translated by a lecturer in psychiatry at Yale University, Ross Deffendorf, showing here a person with a so-called Schnauzkrampf, a form of extreme grimacing, as well as a person on the right in rigidity and catatonic stupor. Another example is so-called seria flexibilitas, or wexiflexibility. And on the right, a form of verbicuration in writing, not in oral presentation of language, but in written presentation of language. And lastly, also from Kraepelin's 6th edition, a recognition that within the dementia precox syndrome, catatonia might lead to more remissions and might have a better outcome than the other forms of dementia precox. Now, in addition to Kraepelin, there are other investigators who have contributed to our understanding of abnormal psychomotor behavior, Eugen Bleuler being an important one. This is a page from his textbook of psychiatry, and I've chosen here the English translation from 1934. And some of you might remember, or if you don't remember, I'm happy to teach you Bleuler's 4 A's. In his mind, the cardinal features of schizophrenia: a loosening of association, the first A, a flattening of affect, the second A, and autism, which is interestingly defined by Bleuler before it was then taken over by Kanner and others for a neurodevelopmental disorder, which for Bleuler really meant that the inner world takes over. It's reality distortion in the form of hallucinations and illusions. And the last of the 4 A's is ambivalence. And you can see here on this page that he had several examples of ambivalence, either ambivalence of affect, ambivalence of will, or intellectual ambivalence. In addition to Kraepelin and Bleuler, there are other scholars who have studied catatonia, and I would say that the preeminent scholar who has contributed to our literature on catatonia more than anybody else in the last 50 years is Max Fink. On the left, you see his chapter that was published in the source book for DSM-4, but did not really influence the diagnostic classification. In 2003, he published a monograph on catatonia, still my preferred reference really for anybody who wants to learn about catatonia, a very well written book. And it was really the evidence that Max Fink had brought together over the years that influenced the decision-making in the DSM-5 psychosis work group that I had the chance to work in the late 2000s and early 2010s. So we published our first paper in 2010, really arguing for a change in the diagnostic classification of catatonia, not making it only a subtype of schizophrenia, like with Kraepelin in all previous editions of the DSM, but separating it from the schizophrenia construct. And then we summarized our considerations in the 2013 review paper. There were 3 facts that we wanted to recognize in a reorganization of catatonia. First, catatonia is often not recognized, and I'm pretty sure that that's one of the reasons I was invited today to educate you a little bit about catatonia. Even in the hands of very experienced clinicians, catatonia is often not recognized. I can acknowledge I trained at Mass General Hospital, and I completed my entire residency at Mass General without ever recognizing catatonia. Well, that has changed by now, but it is still a poorly recognized clinical condition. Secondly, the most important piece, that the majority, 50% or more of catatonia cases, do not have a primary diagnosis of schizophrenia. But rather than completely divorcing catatonia from schizophrenia, the third fact is also important, that a subgroup, more than 10% of patients diagnosed with schizophrenia, also present during episodes with significant signs of catatonia. So those are the 3 things we wanted to recognize in the DSM-5. So these are the 12 diagnostic features in the DSM-5. And these are the important ways that catatonia can be diagnosed now in the DSM. First, a catatonic disorder due to a general medical condition, so-called secondary catatonia, very much akin to a psychotic disorder in the context of a general medical condition. Secondly, rather than making catatonia a subtype of schizophrenia, which were removed completely from the DSM-5, we can now add catatonia as a specifier to any of those 5 primary psychotic disorders. And lastly, that we can also add catatonia as a specifier to a primary mood disorder, either a manic depressive disorder or an episode of bipolar disorder. And lastly, particularly in the emergency room setting and without much further knowledge about the patient's history, we can also diagnose catatonic disorder not otherwise specified, which was not available in previous editions of the DSM. Now, we thought this was rather significant as a change, but then within a couple of years, the ICD-11 went even further. They did not only separate catatonia from schizophrenia by making it a specifier rather than a subtype, but rather they elevated catatonia to a new diagnostic class, moving it out of the schizophrenia and psychotic disorder chapter. And this is really how the review article of this particular change summarized this new diagnostic grouping of catatonia, making it at the same level as mood disorders, anxiety, or psychotic disorders. All right. So now that I've given you the kind of the history of how we ended up with catatonia as we currently describe it, I need to spend a little bit more time to actually tell you what catatonia actually looks like, and also go through the definition of the various signs and symptoms. It was a resident in psychiatry, George Bush, a good friend of mine who always mentions to say that he is the previous resident, not the previous president, who in 1996 published a rather influential paper on a new rating scale to capture catatonia. It included 23 items, and it has been known since then as the BFCRS, the Bush-Francis. That means the first and the last author were recognized in this acronym, the Bush-Francis Catatonia Rating Scale. Okay, 23 items. We took the Bush-Francis Catatonia Rating Scale at Vanderbilt and screened with this instrument more than 300 patients, both in the adult general hospital as well as in the psychiatric hospital. We first looked at the screening instrument, which is an abbreviated version of the 23-item scale. And then you can see in the flow diagram, we removed from our assessment all those patients who did not respond positively to an intervention, the benzodiazepine challenge test. So we used a rather significant validation criterion. So not only the clinical symptoms, as we could describe it with the rating scale, but also we needed to validate that this particular syndrome could be responsive to treatment with a benzodiazepine. That left us with 232 patients that we then diagnosed with both DSM-4 as well as DSM-5 criteria. And now I'm going to show you kind of the overall distribution of those 23 different signs and symptoms of catatonia. On the left, you see the simple frequency, and you can see that staring is the most frequent sign of catatonia, with combativeness and grasp reflex the least frequent. Panel B shows you the number of signs for each of the patients. You can see there that there was one individual, at least, who had 20 catatonia signs out of the possible 23. But you can see that on average, 5, 6, or 7 catatonia signs were diagnosed in the person who met the criteria for catatonia. And then in panel C, we asked, how would the diagnosis of catatonia change if we removed one single item? And you can see that simply removing staring from the diagnostic criteria will decrease the likelihood of diagnosing catatonia by about 4%. That's relevant here because you can see at the bottom, out of the 232 individuals, 209 met criteria using DSM-4, which includes staring, whereas only 168 met the DSM-5 criteria, which does not include staring. We then used a principal component analysis, statistical analysis, to look at relationships between those 23 items on the rating scale. Now, this graph or this table should be read that anything that is listed under column 0 means there were this sign was not present in the patient. So let's say, for example, excitement was absent in 77% of individuals. Then columns 1, 2, and 3 should be read for the majority of items as mild, moderate, or severe. But then you notice that there are several items. I point out row 13, flexibly, which shows a 0 for 1 and 2. And here, the scale actually doesn't have 4 different levels, but rather only has either present or absent. So here it's only a dichotomous decision between present or absent. When we do these analyses, we can identify that there are 3 different components that are associated with each other. They're listed here. And we have labeled them then into 3 different groups. At the top, you see a increased activity. At the bottom in gray, you see decreased activity. And in the middle, you see abnormal activity. Now, interestingly, that even with a principal component analysis of those 23 different items, only 30% of the total variance of all of the signs and symptoms could be achieved with the model. While this was a very statistically significant modeling of those 3 factors, it clearly left the majority of the variance still unexplained. It was this grouping that then allowed us to create a Catatonia checklist, which is shown here. And this is what I'm going to use for the next couple of minutes to kind of teach you about the different signs and symptoms of catatonia. And think about this as a 3-by-3 table. So as a clinician, you can have 3 different sources of information. The first is you simply observe, maybe even from a distance, maybe across the room, or before you have any interaction with the individual. Then you engage the person in an interview, simply asking questions and looking for responses. That's the second source of information. And then on top of observation and interview, you can then touch the patient and perform a physical examination. And you can see that the various signs of catatonia can be observed at any of those 3 levels. And when you do that, the observations then can be grouped into 3 different abnormal findings: increased activity, decreased activity, or abnormal psychomotor activity. So that was our original checklist from about 15 years ago. We changed this a little bit and published this in the Lancet Psychiatry article. And I'm going to zoom in now at the various levels, and I will start with increased psychomotor activity. You will see that the total number of items is actually 25. But the Busch-Francis Catatonia rating scale only has 23. The DSM only has 12. That's indicated in this table. The Busch-Francis Catatonia rating scale actually collapses 2 of those features into 1. Echolalia and echopraxia is considered to be 1 item in the Busch-Francis Catatonia rating scale, and posturing and catalepsy are also just 1. Therefore, the 25 items here convert to 23. And the 12 items that made it into the DSM-5 are indicated here with the asterisk. All right, so let's focus on increased psychomotor behavior first. There's 1 that made it into the DSM, and that's agitation. You can see that there are others that are quite similar, and I'm not going to even define all of those items because they are somewhat self-explanatory. The article defines all of those, but I will focus on the definition of only those that are a little bit more challenging. Then moving from increased to decreased psychomotor activity, just by observation, we can diagnose either stupor or ambitendency. And that requires a definition. Before I do that, please note that staring, the most prevalent catatonia sign, did not make it into the DSM-5, which has led some investigators to propose that a revised version of the definition in DSM in the future should include staring again in the diagnostic classification. So what is stupor? And what is ambitendency and how are they different? Stupor would be defined if there's no or markedly reduced psychomotor activity, and that the psychomotor activity is not related to any changes in the environment. In contrast to stupor, ambitendency is an appearance of being stuck in an indecisive or hesitant movement. So not a lack of movement, but an appearance of being stuck. A perfect example is a patient who's being asked to leave the room, and it might take the person 5 minutes to actually leave the room in a hesitating back and forth and very slow approaching a door and hesitating for minutes to go through the door. Then after observation, we can define decreased psychomotor behavior also in the interview. And here it's primarily negativism and mutism. Again, requires a definition. Negativism is the opposing or not responding to instructions or external stimuli, whereas mutism is no or very little verbal response. Bleuler in his textbook gave a perfect example of negativism. Bleuler was actually very interested in negativism. He devoted an entire monograph just on the feature of negativism. So the anecdote that he includes in his textbook, he does morning rounds, he sits down on the edge of the bed of the patient. The female patient is mute and stuporous and doesn't respond. Bleuler engages in a conversation, but there's no response. Then Bleuler gets up, leaves the room, and as he's leaving the room, the patient sits up and says, "Wait, Professor Bleuler, I want to talk to you." So here, the person able to engage, but only when the other person has moved on because prior attempts were not successful. So here, verbal output, but in a opposing direction rather than in a fluent conversation. And now we are moving to the third bucket. So we've covered increased and decreased psychomotor behavior, and you can see here now that the majority of signs and symptoms of catatonia are considered abnormal psychomotor behavior. Grimacing, which made it into the DSM, was shown already earlier, the so-called Schnauzkampf, as an extreme form of this. But here we need to define stereotypy and mannerism. Stereotypy would be repetitive, abnormally frequent movements that are not goal-directed. So this could be as simple as rocking back and forth repetitively for a long period of time. Mannerisms, on the other hand, would be odd, circumstantial characters of normal actions. So somebody could rearrange their hair and do this constantly. So this would be once or twice a normal action, but here it becomes manneristic. This is the difference between stereotypy and mannerism. I will reserve posturing and the definition of that when we come to catalepsy, because it's related to that. So please hold that for a minute. During the interview, we can observe echophenomena. Echolalia and echopraxia is simply the mirroring of either the speech or the action. So when I rearrange my hair, the person would do the same and mirror my motor acts. Verbicuration and automatic obedience, rare symptoms, less than 5% of individuals with catatonia, need to be defined. Verbicuration is the continuous, directionless repetition of words, phrases, or sentences, or sentences, or sentences, or sentences. So the person would repeat without any clear explanation parts of a phrase or a sentence. Automatic obedience is a mechanical and reproducible compliance with examiner's requests, even if dangerous. Now, this is the one sign of catatonia which is rarely elicited. The exact instructions coming straight from Kraepelin says, ask the person to stick out their tongue because you would like to stick a pin through it. Rather striking to see that made it into the Bush-Francis catatonia rating scale. Lastly, the physical examination can capture waxy flexibility, catalepsy, and rigidity, and they need to be defined now. Waxy flexibility is the slight, even resistance to the positioning by an examiner. So this is important. Waxy flexibility is what you, as the examiner, feel when you actually move the person's arm or leg. A slight resistance, as if you were bending a candle that's warm. Catalepsy is the output of this, the product of this. So after you've moved the person's extremity, arm or leg, the person leaves those extremities against gravity in a rigid posture. Posturing alone without catalepsy is simply the spontaneous and active maintenance of a posture against gravity. So you can see that they're all related to each other, but have made it into the diagnostic systems as different, separate criteria. And here you could see that Diefendorf actually should have labeled this not seria flexibilitas, but catalepsy, because you cannot show the waxy flexibility in a photo. You would need the physical examination and the response of the person while you're moving the extremity. And lastly, I need to bother you with a little bit of German. Gegenhalten and Mitgehen are the two features that also are recognized in the Bush-Francis Catatonia rating scale. They didn't make it into the DSM. Gegenhalten, translated, means holding against, is resistance to the positioning by an examiner that increases proportionally to the applied force. So think about this as being distinct from, let's say, the rigidity exam you might have in Parkinson's disease. And Mitgehen, translated as going with, is the exaggerated movements in response to light pressure. So you can move somebody's extremity by very simply touching the extremity, and then the person will move with you. All right. Those are the definitions of all of those features, and I hope that that is helpful. Again, you have all of those details in the Lancet Psychiatry article. So how does this come about? How does the person engage in all of this motor behavior? This is a well-known cortico-striato-thalamo-cortical loop that starts in M1, the motor cortex, and ultimately ends up back in the motor cortex. With research over the last 20 years, particularly functional neuroimaging, we have been able to show that the activity in regions anterior to the motor cortex, so-called supplementary motor area and pre-supplementary motor area, is increased, and this increased output ultimately leads to an inhibition of the primary motor cortex output. More recently, in fact, over the last 3 years, we have now learned that our traditional model, shown on the left, of pre-SMA and SMA projecting into the motor cortex might have been too simple, that there might actually be regions between the primary motor cortex regions that are actually mediating the integration among those different domains. And that's shown on the right side in the revised model. So rather than the SMA projecting into the primary areas, you have further coordination within the motor strip. And if that turns out to be correct, then that would lead to a significant change in how we are thinking about motor and psychomotor organization in the brain. There's another very helpful review article published last year in Nature Reviews Disease Primers on catatonia. And here you see on the right side the two prominent models of either motor or psychomotor dysfunction. This particular paper also provides some neurochemical explanations, and they are quite helpful as we are trying to think about treatment response. You can see first, left upper corner, a decrease in the amount of GABA released in a GABA synapse seems to be driving some of the catatonia features. And we know that, number one, because the allosteric modulation of the GABA-A receptor, through benzodiazepines, for example, is the primary treatment of catatonia. And on the opposite side of the spectrum, a rapid withdrawal of benzodiazepines, a so-called negative challenge test, can lead to withdrawal catatonia. If you look at glutamate just below, there is a mirroring abnormality of glutamate We do treat as a second and third line agent catatonia with NMDA modulators, amantadine and memantine. And we know from our clinical literature that NMDA receptor encephalitis, which modulates the NMDA receptor, is one of the primary causes of secondary catatonia. And last but not least, of course, we've known for many years that the blockade of dopamine receptors, primarily with classical first-generation antipsychotics, can lead to a well-known syndrome called neuroleptic malignant syndrome, which is a form of catatonia. For all of those who really want to get updated on the current evidence on the treatment of catatonia, I recommend this review in the Journal of Psychopharmacology from 2023. It is the most detailed and comprehensive review of all available treatments, focusing primarily on benzodiazepines and ECT. And I want to finish my own presentation here today with a brief review of our New England Journal of Medicine paper, where we summarized the available literature, but we've also provided a breakdown of catatonia in 3 different clinical settings: the emergency department, an inpatient unit in a hospital setting, and the psychiatric setting. So let's start with the emergency department, where the diagnosis of catatonia can be as prominent as 5 to 10% of all patients seen in an acute emergency room. When we diagnose catatonia using a rating scale like the Bush-Francis Catatonia rating scale, we have to first think about acute psychosis. It is still the #1 diagnosis to consider, meaning either an episode of schizophrenia or another psychotic disorder. It could be a mood disorder with psychotic features. Intoxication as well as withdrawal being more likely, can lead to a bout of catatonia. Amongst them, withdrawal from alcohol and withdrawing from benzodiazepines are the primary situations to be considered. Then, of course, we need to consider neuroleptic malignant syndrome if the person has been treated with a primarily high-potency D2 antagonist. And we need to separate catatonia from the serotonin syndrome. Lastly, we need to be aware of the autoantibody encephalitis that I already mentioned in the previous slide. The treatment in those acute settings is always twofold. First, avoid D2 antagonists. And number 2, perform a lorazepam challenge test, which simply means the administration of 2 milligrams of lorazepam. It could be done PO, better IM, and even better IV if possible. And the observation of a change in the severity of catatonia within the first 30 minutes after the challenge. Let me just briefly review the clinical scenario of autoantibody encephalitis. This was a 14-year-old African-American young woman who was brought to our facility at Vanderbilt after she had been diagnosed with mononucleosis 3 months earlier, and then ended up in an emergency room after days of progressive weight loss, fatigue, weakness, and headache. The patient ultimately ended up in an intensive care unit and was then diagnosed by our consulting psychiatrist because of prominent catatonia to have a form of autoantibody encephalitis. A teratoma was diagnosed. The patient underwent ECT and then ultimately surgery and removal of the teratoma, and the patient left the hospital cured and returned to a previous level of functioning a year later. This is the case report that we described in 2013, which at that time was, to the best of our knowledge, the first diagnosis of an autoantibody encephalitis case based on a catatonia clinical presentation. Dalmau, who really characterized those cases of autoantibody, primarily NMDA receptor autoantibody encephalitis cases, very nicely captured this in this graph. And you can see in the 3rd stage of the illness, which can lead to severe coma and encephalopathy, the patient might be diagnosed with catatonia. Not before, not after, but primarily in that 3rd stage, often presents with significant encephalopathy and catatonia. A case like this was described as a first-person report by Susanna Cahan in her book Brain on Fire, which also was made into a movie. Okay, in addition to the emergence from the medical unit, where our consult psychiatrist might actually see catatonia cases, the differential diagnosis is primarily epilepsy and delirium. There's an ongoing debate that delirium actually can occur together with catatonia. Yes, I'm aware that the DSM does not allow for this. We can actually not diagnose catatonia if delirium is also present, but there's very compelling evidence, and Joellen Wilson in our department has contributed a good amount of evidence for this, that there is a significant overlap, even in the intensive care unit setting, between delirium and catatonia. In addition to the encephalitis cases, we need to exclude other forms of encephalopathy, focal brain lesions, that means tumors and strokes, but also medications in addition to those that I already mentioned. And lastly, we clearly have to think more about catatonia in our own setting, in the psychiatric settings, on inpatient units, sometimes even in the outpatient setting. We have to think about mood disorders first and foremost, because the majority of individuals with a psychiatric disorder who present with catatonia have a primary mood disorder. In addition to that, of course, schizophrenia. And lastly, a growing awareness that neurodevelopmental disorders in the autism spectrum often can present with forms of catatonia that might be phenotypically a little bit different than what we would see in mood and psychotic disorders. And again, the intoxication and the withdrawal are important ones. And at the bottom, I'm showing you that benzodiazepines and ECT are the two first-line treatments. They almost always are highly effective, but there are some treatment-resistant cases. If that is the case, switching from a benzodiazepine to valproic acid, also treating the patient with an NMDA receptor antagonist, like memantine, and in patients with a primary psychotic disorder, after the catatonia has resolved, we have to think about a reintroduction of an antipsychotic drug, because the combined presentation of psychosis and catatonia almost always requires a reintroduction of an antipsychotic drug. In all of those settings, we should use rating scales like the Bush-Francis Catatonia rating scale. We need to pay attention to changes in vital signs. In fact, autonomic abnormality is one of the cardinal features of catatonia. And some also prefer to follow patients with changes in creatine kinase, which is often increased in the acute phase and can respond with substantial decreases even over the course of 24 hours after successful treatment. Lastly, I will leave you with a couple of thoughts that we summarized in our Network Insights article on taking care of a patient with catatonia. It summarizes at the top that it still confuses clinicians, even 150 years after Carlsbad. I hope that my presentation today was helpful in educating you about the signs and the symptoms, but also how difficult it was to get catatonia removed from the strong embrace of schizophrenia and a greater recognition of catatonia as an independent entity. But at the end of the day, we need to think about the body being a readout of the mind, and that we need to understand psychomotor behavior as a way to have insight into abnormal mental states. I can say this in the scientific literature, but a much better review and a much better account of catatonia can be found in the book Bartleby the Scrivener by Herman Melville in 1853. Just please note that this was 20 years before Carlsbad even defined catatonia. But this is a perfect example of a patient who ultimately died of malignant catatonia. And Melville summarizes it in, "I might give alms to his body, but his body did not pain him. It was his soul that suffered, and his soul I could not reach." This person, the Scrivener, who was employed on Wall Street to translate and transcribe documents, financial documents, ended his life only uttering one sentence in the form of verbigeration: "I would prefer not to." including ceasing any oral intake and ultimately passing away in a severe form of catatonia. And I leave you with that, and that was my last slide.
Right. Thank you so much. Yeah, really appreciate the talk, Dr. Heckers. We have time for just a couple of questions. One of the questions that we had come in is asking if you wouldn't mind commenting on the recommendation to hold a dopamine antagonist for a patient with catatonia, and specifically in a situation where a patient has a known primary psychotic disorder presenting with catatonia, and prior to developing catatonia, they had worsening psychotic symptoms. Would you ever consider increasing dopamine blockade, or would you consider their catatonic presentation as a separate thing that requires a decrease in dopamine blockade at that point?
Thank you for that question. It is maybe the most challenging of all of those. Being prepared for that question. This is the paper that I would strongly recommend people to read, the treatment of schizophrenia with catatonic symptoms. And it actually, I hope you can see that, right? You can see the slide? Yeah. So it actually defines this challenge both for the acute episode as well as for chronic psychosis. And in a nutshell, in the acute episode of a patient with schizophrenia who has prominent catatonia features, it is advisable to either stop the antipsychotic or substantially reduce the dose of the antipsychotic. At the same time, if the person is psychotic, let's say paranoid, hears voices, has other forms of formal thought disorder, and also has catatonia, the person will not improve and will not be able to be moved out of the psychosis without a significant treatment with an antipsychotic. So that's where we need to find the balance. Just taking the person off will help with the treatment of the catatonia, but will not allow the person to come out of the psychotic episode.
Got it. Okay, thank you. Another question that came up, so a good number of the attendees here probably primarily work in outpatient practices versus more acute settings like inpatient or emergency. Are there instances where you would have to do chronic management of catatonia versus conceptualizing this as purely something that can resolve in the acute setting?
Yes, the treatment of chronic catatonia, there are really two different challenges. One is an ongoing treatment, extended treatment with either a benzodiazepine or even ECT. We, of course, over the years have become known for the treatment of catatonia, and we have treated individuals with several years of maintenance ECT. Several years, 3 times a week, and any attempt to decrease the frequency led to another episode of severe catatonia. That's challenge number one. But almost always, even after very long treatment, the person actually will be able to do better and ultimately can be weaned off either ECT or even high-dose benzodiazepines. The second outpatient challenge is that there are periodic forms of catatonia. They actually resolve quickly, but they actually are relapsing, sometimes in the form almost like a relapsing form of a mood disorder, including several episodes per year. And that is very difficult to manage because in the acute episode, you might have to titrate benzodiazepines up very quickly, even potentially start ECT, but then is a prompt response to treatment, then you can decrease the dose, but then 2 or 3 months later, you have another episode.
Well, thank you very much. This brings up just about to the top of the hour. So I just wanted to say thank you again for giving us all this update and for making the time to present to us. And thank you everyone in the audience for being here.
All right.
Bye for now.
Thank you.
Thank you.